Hi, it's Andrea, and I'm back again for HIT 210, Chapter 13. This is now Part 3. Aren't you excited? I am. We're moving right along, making good progress, so let's keep going. All right, I promised that I would explain about Category 2 and Category 3 codes. Those are kind of unusual twists that you will find with CPT. So let's talk about Category 2 codes first. They are supplemental tracking codes used for performance measurement. They decrease the need for abstracting information and chart reviews through data collection. So they capture things that are needed for performance improvement, for national reporting, for maybe even registries, public health, data collection, those types of things, or for insurance carriers to monitor what's going on. And it's a way that they can do it through a code rather than you having to send in information in addition. It's part of the claim. The first four characters are going to be numerical. The fifth character will be an F. So if you see a CPT code where it has four numbers and then an F, it tells you it's a Category 2 code and it's going to be used for performance measurement tracking. Okay? Category 3 codes are temporary codes for emerging technology, services, procedures. The data collection on what would otherwise be an unlisted code. Remember in the previous slide and in the previous video, we talked about unlisted codes that, sometimes you have new technology or new services, new procedures that are coming up and they don't fall under anything, so you have to put them in an unlisted code. If they fall under an unlisted code enough, a lot of times they will create a Category 3 code for these items to be able to track the volumes and what's going on with these procedures, where they be performed. And that way, then they can decide if they're going to give them a permanent CPT code. These are just temporary codes. And in this case, they're numerical as well. The first four are numerical digits. The last one is a T. So if you see four numbers and an F, it's Category 2 performance measurement. If you see four numbers and the letter T, that's going to tell you it's a temporary code and they're doing data collection as well. And what would otherwise be an unlisted code. It's something new, something that they're tracking. So you just need to be aware of those. Coding ethically. Yes, yes, yes. We talked about this with ICD-10-CM. It's essentially unchanged when you come to CPT-4. Who can document? You need to know that you should be only coding those authorized to document codable information in the medical record. Because again, codes must reflect the documentation in the legal medical record at the time of coding. So hopefully wherever you go to work, they have a policy about who is authorized to document in the legal medical record. And that is who you're going to code from. When is it documented? You can code it only if it's for that specific episode of care or visit. That's it. You can't code things from a visit or two before or a visit or two afterwards. You can only do it for that specific episode of care. If there's a late entry, you'll hopefully, wherever you work, they'll have a policy about late entries. What do you do? Do you go back and amend the coding? Is there a deadline on when late entries can be done? So you'll want to know about that, because sometimes a provider will be like, oh yeah, I forgot to put that in when I saw that patient. I need to add that. And you need to determine, are you going to code all late entries or only some? Only if it impacts reimbursement, only if it impacts data collection. All those types of things really need to be addressed in a policy, so you know what you're supposed to be doing. What is documented? You code to the specificity you are given. If you're not given specifics, and the doctor or provider doesn't go ahead and go back and give you the updated information that you need when you query them, you can only code to the specificity that you're given. So if they don't tell you if it's left arm or right arm, they don't tell you the percentage of the body part that was impacted, they don't give you the time, you're going to probably want to ask them to document all of those things because you need it. But if they don't, you can only code to the specificity you are given in the documentation in the legal medical record at the time of coding. And make sure you code for medical necessity and appropriateness. If a patient's being treated for something and you don't have the information, you need to go back to the doctor and say, it looks like you were treating the patient, or you were prescribing, or you were assessing or managing the patient for something. Can you give me that information so that we can make sure that it justifies medical necessity appropriateness? Where is it documented? Again, not on a post-it note, not verbally relayed, not from an email, not from a test result. You need it in the medical record, and hopefully your office or setting where you're at will have a policy on that so that you can feel comfortable about where you're getting your information to code. How is it documented? It's got to be legible and clear in meaning, especially if the provider likes to come up with all of his or her own abbreviations and not use standard ones. It's got to be clear, and it should it should not be coded if it's only documented once and never treated or collaborated. If it's only mentioned once, there's no documentation of treatment or a test result that supported that, or something else. You want to be really careful about whether or not you code it, and it would be ideal to have a policy on this as well. So again, coding ethically is absolutely critical. Otherwise, it makes the codes that you assign meaningless, and you're running the risk of fraud and abuse. And we certainly don't want to be doing that. We want to have integrity and be trustworthy. So basic coding guidelines. There are specific guidelines at the beginning of each section. The sections are not limited by provider type or traditional specialty that performs the procedure or service. Example with anesthesiologist. A lot of colonoscopies, the anesthesia, which is usually Versed, which is sedation, not anesthesia, but sedation, is performed by the gastroenterologist that's doing the colonoscopy. So just because you code an anesthesia code doesn't mean it's being done by an anesthesiologist. And you can't, and it's not that you can't use that code out of anesthesiology for a non-anesthesiologist, because you can. Mid-levels or dependent practitioners. These are your PAs, your nurse practitioners that are working under the supervision of a licensed independent practitioner, physician, that type of person. They are considered the same specialty as their supervising licensed independent practitioner. So if you're working in an OBGYN office and there's a nurse practitioner there, when you go to code something that the nurse practitioner did, you're going to code it as being an OBGYN specialty, because that is what their supervising licensed independent practitioner is. And you're going to choose the CPT code of the specific procedure or service performed. Otherwise, you have to use an enlisted code. But if there is a procedure or service performed that has a CPT code that describes it, that is what you do. Again, an unlisted code is what you do, sort of last resort if there's nothing else you can do. All right, helpful info in the CPT book. Why do you need to know what's in the CPT book? Because it could be helpful. There is review of prefixes, suffixes, and roots. That old medical terminology class will come back to get you. So you want to, if you're stuck and you're not sure, you can go and review those. There are lots of anatomical illustrations. There are procedural illustrations, because maybe you're not sure exactly what's gone into that procedure. There's illustrations that help you see that, or help you query a physician to say, was it this, was it that? Body planes. Knowing the body planes is very, very helpful, especially if you end up working for an orthopedic office and you're talking spinal surgeries and things like that. E&M tables. That is evaluation and management codes. There are tables that help you determine which code to use, and that is very helpful. Very, very helpful. So make sure that you familiarize yourself with these things so that if you get stuck or you need some help, you know where to go to find it. So let's talk about evaluation and management now. When you look at office visits, you are going to break it down between new and established patients. Is this patient new, never seen before, or is this an established patient that's been seen before? Hospital visits, you're going to look at whether or not this is the initial encounter by the provider with the patient, or is it subsequent? Is the patient in observation status, or are they inpatient? And again, are they a new patient? Is this the first day they've ever seen the patient if they're a hospitalist or a consultant? Or is this an established patient that they've seen before, maybe a couple of days ago? Consultations, I should say. Is the patient an outpatient or an inpatient status? And remember, observation patients are considered outpatient status. New versus established patient. Okay, so we move on to ED services. Again, new versus established patient. Or is this EMS ALS care? So you also need to be aware, is this a supervision of EMS with a patient that's on their way, or is this a new or established patient that they're seeing in the ED itself? Critical care services are going to be all based on time, because it doesn't matter whether it's a new or established patient. It doesn't matter whether it's initial or subsequent encounter. For the most part, your critical care patients are going to be inpatient status, unless they may be a drug detox kind of situation where they're just being supervised for a short period of time before they can be released to an outpatient setting, or transferred to an inpatient behavioral health setting or substance abuse setting. So critical care services are only based on time. Nursing care facility services, you get into the new versus established patient, initial versus subsequent versus discharge versus annual review encounter. So be watching that. Other care facilities like group homes, assisted living is just new versus established patient. Home services, house calls, a doctor on a cruise ship. You may have to go for something really wild like that someday. A doctor that goes to a hotel, a doctor that goes to a campground. Is this a new versus established patient? Those are all under home services. And yes, there are CPT codes for those. Prolonged services, inpatient or outpatient, with or without direct patient contact with a licensed independent practitioner versus a dependent practitioner like a PA or a nurse practitioner. So that gives you the whole kind of breakdown of E&M codes and what you need to be watching out for. We are now at 13 minutes, so I'm going to stop this part and we will be back shortly. So hang in there, catch a quick break, and then let's pick up with the next video.